Hello, good morning and welcome. I'm Dr. Nitish. Today we are seeing the basic abdominal imaging. Here the complete tries to reach to the very basic and initial things in imaging in the area of abdomen for MBBS students. And here we'll go through basic abdominal imaging. This is sonography image, and here we are seeing the Doppler image, color Doppler image. What we are seeing here is on the sonography image, this cylindrical structure, blind ending, which is appendix, is actually blood vessel. So this appendix cylindrical structure is getting compressed by probe. So when it is normal, it shows compressibility. And when it is abnormal, inflamed, it doesn't show compressibility. It is more of a stout, very painful, as well as peripheral fat will be inflamed. So we'll see those images. CT scan is modality of choice to evaluate appendix, and ideally at post pain when we suspect appendicitis, CT scan is a modality of choice actually. So limitation is only one, that is ascites or very thin patients where the fat is not surrounding the appendix. So here, like we are seeing, air containing small, well-defined, thin walled appendix, which is normal. Here also we are seeing normal appendix. This is in a different oblique plane actually. What we are seeing is sequence here, in appendix here. This is normal appendix. The fat around it is uniform and extreme fat density. See the next image. Here we are seeing appendix is here. This is fluid-filled inflamed appendix, enlarged appendix. What is important is that around it, the fat is shown thickening. Last image what we saw is like this inflamed fat we didn't see around the appendix. Here we are seeing appendicular wall is thick, edematous, as well as adjacent fat. Periappendicular fat shows severe inflammation. This is the case of appendicitis. As well as appendix is enlarged, fluid-filled, adjacent periappendicular fat stranding is remarkably seen, enlargement and inflamed. Again, on CT scan, we had seen normal image where a thin appendix we had seen. Now here we are seeing enlarged appendix with fluid within. What is important here? This is a contrast study. We can confirm this is a contrast study by seeing the aorta. Aorta is like showing enhancement because of blood is mixed with the iodinated contrast. Now again, we are coming back here. Appendix is in here. The wall is relatively thick and which is showing enhancement on contrast study. Whenever there is inflammation, the vessels, microblood vessels are more, the perfusion will be more, edema is less, so more perfusion will be there, and that enhancement is in this area. So here are three findings. One is enlarged appendix, second is wall is thick and showing enhancement, and third is a very important finding is periappendicular region fat, which is showing changes, which is appearing inflamed. The inflammation is on CT scan, what we call it as a fat standing, as well as the cloudiness of the fat around the appendix. What we are seeing is periappendicular region is completely normal, peritoneum, uniform, hyperdense signal. Here it is, the signal is altered and which appears hyperdense or isodense and showing fat standing. This is the case of inflamed appendix or appendicitis. Secondary to appendicitis, this we get to see many at times, right? Iliac fossa, lymphadenopathy. It is more common in the children actually. Here we are seeing multiple, this is ultrasound image first and foremost, sonography image, which is showing right iliac fossa, multiple enlarged lymph nodes. There are multiple enlarged lymph nodes also. And this intervening thing is fat. So basically on ultrasound images, these are the lymph nodes. And in pediatric age group, they are commonly seen in the normal situations also. Some amount of lymphadenopathy will be there. Now here, cases of chronic appendicitis. We are seeing thick-walled appendix with adjacent minimal fat standing. What is important here is the draining lymph node area, lymph nodes are enlarged. Go to the next image. Here, this is bowel loop. This is the lumen of the bowel loop, cecum and interluminal region. The wall of the cecum is uniformly hypodense, echoic, and this wall, hypoic wall, is thin. Adjacent to it is outpouching. This is actually diverticulum, and adjacent fat is showing excessive inflammatory changes, extensive inflammatory changes. So this is the case of diverticulitis with adjacent inflammatory fat. This ultrasound image again, what we can see this ultrasound image with inflamed diverticulum and adjacent inflamed fat. Here again, we are seeing diverticulum with inflamed fat around. This is a case of diverticulitis. We are moving on to gallbladder. This gallbladder, uniform wall, a relatively thin wall. The wall measures up to 2 mm. Within that, what we are seeing, hypoechoic uniformly or unechoic. Fluid is unechoic on ultrasound. So this is interluminal region of the gallbladder. What we are seeing here as a shining pearl kind of a thing, which is reflecting all echoes, sound waves back and reflecting it is. So this is calculus. The key point here is there is a shadow. So the source of ultrasounds are towards the apex of this beam, from where the sound waves are coming, and on the other side of this calculus, there is a shadow seen. So this shadow is called acoustic shadow. This is diagnostic of a calculus, range calculus, which is like posterior to that. Actually, the sound waves doesn't reach, and this doesn't reflect back, and this acoustic shadow is seen. So again, I'm repeating, is the calculus, interluminal calculus, gallbladder is normal. So this is the case of calculus without inflammation of the gallbladder, without cholecystitis changes. This is MRI image. What we are seeing here is this is gallbladder. This is T2 weighted image showing human as ISO2 hyperindex of the gallbladder, and there is well-defined area without having any signal. This almost signal void is here. So this is calculus. So bone cortex as well as calculi does not show any signal. So that's how they look dark on most of the sequences, all sequences. So this is intraluminal gallbladder calculus, which is well defined and without any signal. There's a signal void. CT scan image where there are some well distended gallbladder. The wall is thin and uniform. Adjacent fat is maintained properly seen, like a normal fat intensity, fat density. This is liver around, liver is showing normal density, and this is pancreatic region here, it's duodenal here. So this gallbladder well defined, thin wall gallbladder we are seeing here, with bile within, which is showing uniform, but in the dependent region of the gallbladder, there are multiple small hyperdense calculi. Most of them are oval to round shape. They are well defined. They are like multiple calculi are seen. They are seen in the dependent region. This is multiple GB calcs without the cholecystitis. This is again a CT scan image, but here what we are seeing is purely hypodense cholesterol calculi, non-calcified. Cholesterol as a fat, this is seen as a hypodense areas within. This is again very important additional thing we are here will discuss. This is CT scan coronal image, which is covering common bile duct, hepatic duct, and common bile duct region up to the duodenum. What we are first and foremost observing here is a dilated CBD. CBD is significantly dilated, but on CT scan, we are not getting to see any calculus because most of the calculi on CT scan, they are isodense. They are not seen on ultrasound, they are seen on MRI, they are seen, but on CT scan, when calculi are not calcified and isodense to the bile, they are not visible. Same patient, we have done another investigation, but we'll see first what are the things to be noted here is hepatic duct and gallbladder and CBD are showing common bile duct is showing dilatation up to the terminus. This is duodenum, and this is without any homogeneous appearance, without any focal area within the dilated CBD hepatic duct region. Now we are seeing another image. This is ERCP, whereupon optic fiber scope is inserted in the duodenum from the ampulla. Catheter is sent within. Here we are seeing the thin catheter, guide wire catheter, and then the contrast is injected. So what we are getting to see here is the contrast injected portion as a uniformly darker one, and the calculi, which are multiple calculi, which are like They are occupying the luminal space. So that particular area, contrast is not getting uniformly spread, so that because of calculus, contrast is away. So this area is multiple, near spherical, filling defects are seen. Those are the calculi on the ERC. This is parallel to ERCP, non-invasive, relatively, completely non-invasive. And this is investigation done on MRI. It's called MRCP, magnetic resonance column. So here, what we are seeing is dilated CBD is a duodenum. Distal to the distal region of the CBD showing two calculi actually. Is a one obstructing calculus here, which is signal void, darker, and here again interluminal non-obstructing calculus, which is relatively floating. So two calculi are seen. This is completely obstructing calculus in the ampular region, which is causing complete obstruction, leading to proximal CBD dilatation. Here we are seeing intrahepatic biliary radicals. Those are also prominently seen, and CBD is dilated. Secondary to obstruction of ampullary region of the common bile duct. And here we are coming very important features when there is a cholecystitis. So ultrasound is often used, very commonly used modality to diagnose cholecystitis, and it's diagnostically very important. So what are the things we get to see in cholecystitis is edematous thickened wall. Normally, it shouldn't exceed more than 2 mm to 3 mm. So this is almost 4 or 5 mm wall. Here, thickened wall, gallbladder has. Here we are seeing bile with some echoes within. So sludge or microstones are here within the gallbladder. Very important point on ultrasound while diagnosing cholecystitis is Murphy's sign. What is Murphy's sign? Is when we compress the gallbladder, when the probe is kept over the gallbladder region and the compression is given. So normal gallbladder will show compression, but the inflamed gallbladder will not show compression. So non-compressibility is a feature of Murphy's sign, as well as the patient will have pain on compression, but gallbladder will not show any compression. It will not get deflated or shape will not change. It remains spherical. So here what we are seeing on this image itself is the compression is put on. So the how to determine this on the image is we can see the peritoneal layer is getting compressed here, abdominal wall to peritoneum. Here it is normally seen, but here it is just in the region of gallbladder. It is compressed on the other side and showing less thickness here. Though, despite of putting so much compression, gallbladder is not getting flattened. Its shape is not changed at all. So this is inflamed, stout kind of a gallbladder with thick wall. The Murphy's sign is positive. It's a positive Murphy's sign. So again, I'm repeating, this is one of the very important key signs in diagnosis of cholecystitis. It could be sometimes calculus cholecystitis. It doesn't mean that suppose calculus is not seen interluminally, still it could be cholecystitis, if features are there on ultrasound, other features of inflammation of thickening of wall, as well as the Murphy sign present, where the compressibility is not seen for gallbladder lumen and pain is on compression, on the pressure. CT scan, this is case of cholecystitis. What we are seeing is a contrast and not CT scan image through the region of gallbladder. What we are seeing is relatively enlarged gallbladder with a thick wall, thickened wall. The wall is shown kind of irregular. The thickness is not uniform, non-uniform wall thickness is seen, as well as the wall, thickened wall is shown enhancement on contrast study. This is a contrast study, as I said. So on contrast study, there is, you can see this isodense is this muscle, and here we are seeing hyperdense. Hyperdense means more out to the whiter side. So contrast agent uptake is there because of inflammatory changes here in the wall. So what we are discussing is enlarged gallbladder, thickened wall, the thickened wall which is already thickened, showing enlargement as well as contrast uptake. So contrast uptake is seen in the wall. Additional thing is pericystic or adjacent to the gallbladder wall, there is a fat standing. Here we are getting to see extensive fat standing around the gallbladder because of inflammatory changes. So adjacent to gallbladder, the fat is inflamed. When fat is inflamed on CT scan, it loses its homogeneous dark appearance and the little bit strands like watery appearance will be seen. This is acute cholecystitis case. Here another image of a gallbladder. What we are seeing here is well-distended gallbladder. Here we are seeing two things here. The gallbladder is shown bile is on ultrasound unequipped almost, but wall is also important. Wall is also uniform and not inflamed. What we are seeing is along the posterior wall of the gallbladder, there is irregular mass arising from the wall. So there are two, three important things what we are observing here is non-moving mass, lobulated soft tissue mass seen arising from the wall of the gallbladder. And on Doppler color study, what we are seeing is there is vascular, inside vascularity is seen. So as we know, malignant lesions are more vascular and they show vascularity. So on the Doppler, it can be picked up. There is soft tissue mass, interluminal growth with increased dilated internal vasculature. So this is a severe gallbladder malignant lesion. Here we are seeing there's a fat standing in here. Here, small amount of air is trapped. On CT scan, what we are seeing, cloudiness here, that's increased density, uniformly, how it is like subcutaneous fat or peritoneal fat in other normal region. Here there is a increased density along the fat. This is inflammatory region. What we are seeing is an intestinal loop here, where the edematous wall is seen irregular and lumen is collapsed. This is again a case very important in pediatric age group. what we are seeing is a fat, similar fat density area within a wall, spherical wall with some blood vessels also. So this is case of intersection. Along with in the septum, there is mesenteric fat is gone, as well as some blood vessels are also seen here. And the thickened band, inflamed band is seen here of intestinal root within you. This is case of intersection. Here what we are seeing is dilated multiple small bowel loops are there. Okay. Suddenly there is a normal distal loop is there. Here, ascending colon, proximal to circumflex, this area is in normal. Here, ascending colons, the mid colon region, that's also normal, no wall thickening or not dilated. But the small bowel loops are showing frank dilatation and food filled area. So there is a friction in between this normal distal small bowel loop and these are dilated loops. This is the case of small bowel obstruction. Here again, we are getting to see multiple dilated loops are there. Here, fluid levels are there, but that doesn't matter much at fluid levels per se. But then the diameter of the small bowel loops is seen increased. Here we are seeing free air. Free air is better seen on large window. That's like a bone window or a lung window. We can see free air is similar. Free air is like separate from interluminal air. Interluminal air is within the lumen with a thin wall. We can make out by the pattern of it. And free air, by and large, we get to see at certain areas only, just below the peritoneum. Here we are seeing along the wall of along the peritoneum, we are seeing free air. The free air is secondary to perforation most of the time. Duodenal perforation, appendicular perforation by convention, it doesn't give free air. Appendicular perforation. But then duodenal perforation, other areas of any perforation will be free air will be seen. This is uterus, where we are seeing complex mass next to the uterus, which is relatively hypoequic, fairly defined. This is a normal fat. Here, what we are seeing is ascending colon, and we are getting to see inflamed area. Inflammation is there. The patient is symptomatic, and this area that we are seeing the isodense ring. This is typical appendicitis. Appendigitis. Typical appendicitis. So this is seen along anterior wall of colon. It's very common in sigmoid colon region. Second common is descending colon, but it can occur anywhere. So what is the diagnostic point here? These are like fat, mesenteric fat is here. So similar fat density area is seen within. Around that, there is a soft tissue, and adjacent to that, there is inflammation. So this is typical appendicitis. This is many at a time self-limiting condition, and within few weeks, couple of weeks, it gets settled most of the time on its own. It's a self-limiting condition. This is another example. This is sigmoid colon here. We are at the level of femoral head. So in the pelvis actually. So this is sigmoid colon. So along the sigmoid colon, articular appendicitis is very common. And here we are seeing fat within, like similar density fat within the region. Peripheral region is seen as uncontrastable, mildly enhancing area. For example, there is a fat stem. So again, a case of epiploid appendicitis. Epiploid appendicitis. Here we are seeing symptomatic patient for electric calculus on ultrasound. Many times we don't get to see because of window, because of patient, because of the size of the calculus. When small calculi are there, but they can cause many of times obstruction. So here we are seeing tiny calculus lodged in the ureter, and in the symptomatic patient with this finding, we are confirming that like it's ureteric calculus. What is additional sign here is ureter. When it gets obstructed also is a thin thing, but when it gets obstruction causes inflammation of ureter wall, and this edematous wall around the calculus is seen. When in symptomatic patients of ureteric calculus, when the wall of the obstructed calculus is like shows some hollow kind of a soft tissue thing, so that represents edematous changes in the adjacent ureteral wall. This is one of the important signs. Very helpful in diagnosing small calculi, obstructed calculi. Here we are seeing it's very clearly demonstrated thing. We are seeing here left renal pelvic system is dilated. And when we compare on the right side, there is a renal sinus fat seen normal. On the left side, because of dilatation of pelvic system, that is getting compressed, as well as this urine field left pelvic system is dilated, suggestive of hydronephrosis. Below that, we are seeing this hydroureter. Ureter is showing remarkable dilatation and it's filled with fluid. Distally, in the lower ureter, maybe probably 5-6 centimeter proximal to uretrovesical junction, there is obstructing oval calculus, which is causing complete obstruction. So the proximal ureteric dilatation, hydroureteronephrosis. Hydroureteronephrosis. On the second image, we are seeing it's a different patient. We are seeing calculus in the upper ureter, left upper ureter. Again, same findings are there almost. One is sinus or pelvic system is dilated, and sinus fat is reduced here, and ureter is showing proximal to obstruction, ureter is showing dilatation. This is the case of pancreatitis. We are seeing edematous pancreas with absent fat stranding and corrections. Here, the pancreas shows enlargement, absent fat stranding is there, extensive, and minimal fluid collection of the regions. With this, thank you very much. With the end of it.